Good morning. I'm Joachim Roski. I'm a principal with Booz Allen Hamilton, which is a large federal healthcare consulting company in Washington, and I do work with most of the large federal health agencies around AI and health. And to some extent, I'm a little bit of an usurper in joining Michael and Sonu's team because I'm not based in academia, but hopefully was able to add some perspectives that are of value. So I joined Booz Allen in about 2011, and prior to that, I worked at the Center for Healthcare Reform at the Brookings Institution in Washington, and this was in the late 2000s. And what we were trying to figure out and work on with stakeholders, legislators, and others is how do we move towards value-based care, and how do we pay for care in ways that's different than how it has happened up to that point. So there were questions on the table such as, well, what is value in healthcare? How would you even measure that? What is the role of providers? What is the role of health plans and other actors in the system? And as we were working on these issues, it became very clear that there are a number of critical requirements that had to be in place in order to make that happen. One is we would need to be able to connect data about the same patients as they travel across the care setting. We would need to make sure that those who make decisions in healthcare, be they consumers and patients, that social network, or be they clinicians, that they actually have decision aids at the time that they're making a decision to make that happen. That we had the opportunity to continuously trawl the generated data in the background to look for opportunities for waste elimination and so forth, and that we would be able to not only look at medical chart abstraction data and insurance claims, but data that might be generated by patients, electronic data that would be generated during the care process, and so forth. In 2008, 2009, as we were working on these issues, that seemed a bit of a pipe dream, to be quite honest with you. As we were working with large hospital systems, they had just begun the process of installing electronic health medical records. As a matter of fact, some of these hospitals had up to hundreds of standalone clinical healthcare data collection systems that wouldn't talk to each other. Same, of course, was true on the medical group side. The implementation of electronic health records had just begun, more or less. And then on the health plan side, they would try to measure clinical care quality through insurance claims. We know the validity problems that exist with that. The data is usually 3 to 6 months old before you can actually use it for any of these purposes, and so forth. So we were trying to drive value-based care when we didn't have the infrastructure really in place to make that happen. So at the same time, there were interesting developments happening. The iPhone was invented or came on the market in 2007, I believe. The iPad came on the market in 2010. Today, it seems like it was eons ago, but it was really just a few years ago that that actually happened. Then in 2012, Harvard Business Review declared that data scientists would be the sexiest job that exists, and looking at this good-looking crowd, that's probably true. When I joined Booz Allen, though, in 2011, I became aware of a lot of other developments. So Booz Allen Hamilton actually started out by doing a lot of work for the Department of Defense, the national security apparatus, or intelligence agencies, and so forth. And there were things happening, and there were data collection and data analysis approaches used that I had, frankly, not really heard of. So they were operating with data lakes. They were operating with the early stages of image recognition, pattern recognition. There were early experiments around speech recognition, video analysis, and so forth. All of these things that really hadn't entered healthcare, but today are much more real, and we will talk about that. So what we want to do today on stage is I have invited 3 colleagues who will talk about some of the issues that we are talking about in our chapter 3. We will talk about how AI has already entered and maybe further driving the opportunities for patients and consumers to become more of a driver of their own health. We'll talk about clinicians and how AI is changing and will be changing the clinical care delivery process. And we will talk about population health and public health and how that could be driven and will be driven by AI. In our chapter, we also talk about the huge opportunities that exist to use AI for administrative processes and to take out excess costs related to redundant and superfluous administrative processes that we could eliminate. We won't talk about that today, and we won't talk about the opportunities for AI to drive discovery, research and development, drugs, devices, and so forth. Huge topics, huge opportunities, but within 45 minutes we had to be a little bit economical about that. So what we want to do today is I'll chat with my colleagues here on stage for about 35 minutes, and then we will move to a Q&A session afterwards. So let me introduce who we have. We have here Dr. Ronak Trivedi. She is an assistant professor in behavioral sciences and psychiatry here at Stanford. She is an expert in caregiver opportunities to help caregivers take care of patients and support them in their health processes. She is a site lead for a major foresight project that looks at these issues. We have Dr. Paul Tang. He is the VP for healthcare transformation at IBM Watson that I'm sure most of you will be familiar with. He's also a practicing physician down the street at the Palo Alto Medical Foundation. And of course, many of you will know that for decades, he has been a leader in this country around quality and how we can improve it through better use of IT. And we have Meredith Barrett, who is a VP from Propeller Health right here in San Francisco. Propeller Health is a digital health company, and through their use of sensor technology, AI, and others, has a great track record of improving health, and Meredith will talk about that on stage. So without further ado, let's go ahead. So Ronak, let's start with you. Where do you see AI has already made significant inroads into supporting patients and their care network, if you will, or their support network in terms of improving health?
I think we've made a lot of inroads with patient-facing and consumer-facing. I'm wearing a watch, probably a lot of you are wearing things like this that are actually doing a lot of getting a lot of information and a lot of health information that's being collected. Where I think we have a sort of the next way where we need to go is starting to think about how does the social context can it be leveraged to both include them in the information that is being collected? So how do patients share that information in a way that they're sharing other information, as well as how can the caregivers or the other family networks, how do they use that information to feed it back to the providers? Mm-hmm. I would say these are the two places. In the caregiver world where we have seen some advances are for dementia patients, there's these robots called Pero, and there's a couple of others where I've been doing some pilot testing with dementia patients. So some of that helps keep the dementia patient, kind of keeping them soothed and keeping their quality of life better, and that offsets the burden of the caregivers. But these are small pilot studies, and we have a long ways to go before we can sort of show that this is influencing patient and caregiver outcomes.
Are there particular projects you could think of that had amazing initial results in terms of improving the health of consumers and or supporting their care network? Any specific examples that come to mind? For the patients, there's actually a lot of really great chatbots type of interventions that are providing mental health care and psychotherapy type of care. And those have actually been shown to be very effective, almost as effective, which obviously Can you explain what a chatbot is and how that would work? It
basically works as an algorithm, and they learn what the patient's problems are, and they're initially developed to be very kind of basic and conversational, but then they learn over time to be able to be supportive more to the patient. And people are using these to provide care to patients directly. Rural Australia has had a lot of great projects around this where they've reached people that would normally not have access to psychotherapy, and getting them connected to these AI conversational agents who can then provide the therapy and provide the support. Again, with the caregiver, there haven't been big empirical studies around it, but a couple of the robots that I mentioned and we cover in our chapter, we talk about how these are actually used, or they're really patient-facing, but they do seem to have some offsets for the caregivers, because the caregivers then feel either they can monitor the patients better, or they feel the caregivers are feeling more entertained or feeling more soothed, and they can take a little break.
Great. Paul, let's turn to you. We heard here about, hype or peril in terms of AI. What are you seeing today in your practice or the practice of your colleagues, how AI is already making a difference, or has it not really arrived yet in terms of day-to-day care?
The question of hype or reality, I mean, I think we're clearly in a state of exuberance and bordering on the hype, and we want to avoid the winter of the third winter. How would we know whether it's real or not? I think it's when we stop talking about it. So we don't say, AI Siri, what's the weather today? Even though we know Siri uses AI. We don't say AI Google Maps with its incredible prediction of when we'll arrive somewhere. And that shows how useful it has become is when it fades into the distance. And I think Bob even talked about that, and Lloyd referred to it in the airline engines. In AI right now, it's not touched the practicing clinician in that kind of way, I don't think. There's some isolated use cases in limited domains. Imaging is a great area for it because all of those bits of data are available to the machine to learn, and we have incredible data sets with labeled, in other words, ground truth of, well, what do these bits represent? So that's really important to teaching. So in melanoma recognition, in diabetic retinopathy, in masses in CT and MRI, some of those areas are where the machine can play a role. Probably it plays a role in what's not there more usefully than what is there. So for example, most of the images are normal, and the machine probably can recognize normal, just like normal EKGs as well, better and then sort of relieve a lot of the burden from the radiologist. Another area is becoming more commonplace, and that's these predictive algorithms. Sepsis was mentioned, of course, is a big killer. Taking all that information and digesting and saying, hey, I'm going to give you a bit of an early warning on that is very helpful. Codes, cardiac arrest is another area that's been used. And of course, 30-day readmission. So those are ways where, in a sense, it's smart data analysis, where the machine is currently using the data that's available and predicting or using it to help the human physician who processes 7 plus or minus 2. So those are today's, and I think there's a lot of excitement about the future, which is maybe even just only 5.
And so would you say the examples that you listed, would you say that has entered routine care, or is it just vanguard organizations are relying on this technology?
It is entered, and I think it's a little bit more towards the vanguard. Mm-hmm. So the good news is we have wired up the country just literally in the past 5 years. So all that EHR data and hospital data is available. More of these prediction algorithms have been used in the hospital setting because there's just so much information and an intense time frame. So I think you are seeing, probably more than leaders, the output of those kinds of algorithms already showing up in care, particularly in the ICU.
Meredith, let me turn to you. We heard in one of our introductory comments earlier today that about 75% of the variance in health outcomes is actually not determined by genetics or medical care as it is rendered, but by environmental, behavioral, and other factors. Now, you and your colleagues worked with the city of Louisville, Kentucky a while back and published an amazing paper last year in Health Affairs around using AI technology, sensor technology, to work at a community level to address the 75% to some extent. Can you talk a little bit about that work and maybe explain to us what the opportunities more broadly might be to use this kind of approach and technology for public health or population health?
Absolutely, yeah, I think there is a lot of promise there. Public health practitioners are attempting to understand patterns of disease across populations and then use that information to protect health, but they are oftentimes very limited in the data they have access to. Whether the data are temporally lagged, it could be months or years before they get access to the data, or spatially aggregated. So our partners in Louisville didn't have access to asthma morbidity data higher than the zip code level. So Propeller was really founded to try to address that issue. If we could collect better data on where and when respiratory disease symptoms were occurring, could we use that information to actually learn what was driving symptoms and then turn the conversation more towards prevention? And so really from there, I think to your point, what we try to do is we have this signal collected by sensors from inhaled medications for asthma and COPD. We collect the date, time, and GPS location of use. And then from that information, we add in over about 80 different social and environmental data layers to really put that medication use into context. And so we're trying to use that information to again, better understand what's driving symptoms. And this was very valuable for the city of Louisville, Kentucky, which has a long history of air pollution and a large burden of respiratory disease. So we partnered with the city there to enroll participants, residents in the county. We enrolled just over 1,200 people in the county, collected data for over 2 years, and ended up with a data set of more than 80 million data points, which represented where, when, and in what environmental context people were experiencing symptoms across the county. And so one of our goals was to help patients or help those residents better understand and self-manage, learn their own unique environmental sensitivities. We also wanted to help inform clinical care, adjust medication treatment as necessary, but really try to apply those data points to understanding drivers of respiratory disease and then turning that into actual policy decision making. And so we partnered with the city, used machine learning methods to understand the relationships between these drivers, social environmental drivers of respiratory disease, and helped and really put that into map format, visualization of the data, and an estimation of risk at a neighborhood level to help have that conversation with the city to identify which neighborhoods were most at risk for respiratory disease, where they should start to prioritize their action with limited funds, and also what types of interventions might be the most effective. And so tree planting strategies came out of this work, tree removal mitigation strategies, recommended truck routes, as well as zoning updates. So really kind of practical applications of that learning.
You know, what sort of struck me about your work is that, you know, when you're used to working inside hospitals or large medical groups, trying to get doctors all to come together under one agenda can be a challenge. I can hardly imagine what the challenge is to do that at the community level, where you have politicians, you have administrators, you have the health systems. Can you share some insights about how do you get this idea, how do you get some sort of shared vision about what the possibilities are and what could come out, so it's not just another research project?
Right. And I think that really gets to a key point. It was not only a key challenge, but I think also a key strength of this program. We from the start, it was funded by the Robert Wood Johnson Foundation, and they were really pushing us to bring the stakeholders together who all had a vested interest in improving outcomes locally for respiratory disease. So we partnered not only with the city, so 7 different city agencies, mayor's office, sustainability, public health, air quality, transportation, housing, but also brought in health systems, local health systems, specialty clinics, and local payers, in addition to community groups, to really kind of bring the stakeholders together. And that was challenging. It was a lot of work to bring all of those people together, but I think it also strengthened the outcomes and actually made there be tangible benefits at the end. I would just make one more point. When we were planning this program, what we heard from our public health partners was that they could not use these data to inform their planning unless the data really represented what asthma and COPD looked like across Jefferson County, Kentucky. And so they really pushed us, as we're planning recruitment and enrollment, we have to make this representative of the people that we have in our county. And so to achieve that, we came up with a pretty broad recruitment strategy where we were enrolling not only in Medicaid clinics and federally qualified health centers, but also in specialty clinics via social media platforms and community groups and employer health fairs. So to really try to achieve not only a geographic balance, but also socioeconomic and demographic balance. So that was really critical to the partnership as well.
All right. Now I'd like to turn to more of a future view and how fast the pace of change is. Tomorrow, 30 years ago, the Berlin Wall fell. In 2007, the iPhone came on the market. Here we are today, using amazing technologies on now my iPhone 11. Let's talk about 5 years from now. What you think will be possible and what do you think might have become routine? Let me start with you, Ronak. I'm reminded because I'm just personally now in the situation that I have an elderly mother who needs more help than she needed before, and she needs people around her to help her, which can be a challenge because she lives in a rural area. Can you talk a little bit about what do you think is coming in terms of supporting people in their homes, elderly people, for example, with different types of conditions? What can AI do in the future, and how likely is it, or what would we need to see to make sure that actually happens as opposed to it just being some fantasy?
Yeah, and caregiving, you just pointed out, is an everyone problem. It's going to affect us all at some point or the other. We're going to provide care, we're going to receive care. So we're in the middle of what we're now recognizing is there's a growing aging population. We're getting really good at getting people to live longer, which is great. But what's happening is that the number of people who are able to provide care, family members and friends, is dropping. So AARP projects that by 2050, we will have about roughly 4 caregivers or family members for every one 80-year-old or older person, and right now the ratio is about 7 to 1. So that the shrinking family size, and as the diaspora of the people moving out of their kind of home communities changes, we're going to run into this issue more and more. And I think the more that AI can start be leveraged for dealing with those kind of issues, not just issues of monitoring the healthy folks or providing clinical care, but understanding that there's a larger social context in which we're going to be operating or already operating, the more we're actually being more forward-thinking. In terms of what we would need to do, I think Dean Miner sort of referred to the recognition that we have this social and behavioral determinants of health that people are now recognizing. Well, the reality is those of us who have been psychologists and sociologists, anthropologists have recognized that for a very long time. They've just been siloed out of the mainstream medical care. So the more we can bring different disciplines to the table, behavioral health scientists who understand behavioral change and why behaviors change and why they don't change and how to maintain behavior change, ethics expert who can mitigate not just a potential of technology, but also understanding that there's a human impact and a human cost to these technologies, and we need to mitigate that. The more we bring different disciplines to the table, community members who are experts in their own lives and who understand their own personal problems, the more we're actually really recognizing the potential of what AI can do as a tool for us as humans and for humanity.
Do you have specific examples? So for all you venture capitalists out there, what is the one thing that you think will be here to stay in 2025 in terms of better supporting patients and their caregivers?
If there's a venture capitalist who wants to work with me on that, I can think about. We've talked about a lot, and we are going to talk about a lot of the things, which is that how do we provide better medical care? I mean, that piece is what's really kind of driving the field and the conversation we're having today. I think to make it stay and to make it stick, we have to rope in the people who it's eventually affecting. When we did our chapter, one of the reasons that we did this full scan of what are the type of, not just science out there, but businesses and how are they developing products. And really, there's no real strategy to actually involve the social support systems and bring them to the table to understand the impact. So if I'm getting, let's say, an irregular heartbeat on my Apple Watch, if I want to communicate that to my family in some way, I don't have a really easy way of doing that, and they don't have an easy way of accessing that. And so I think that thinking about those, to make things stay and stick, you need to solve the problems that we have, not just for the clinicians, but for the patients and their families, but also make sure that we are using the science and the theories that we know exist out there to build the products that are stickable, if that's a word. If not, I just made it up.
All right, very good. Paul, let's move to the clinician team. You sort of talked about that vanguard organizations are beginning to integrate on a more routine basis some forms of AI. We also heard a little earlier today a theme around that in the near future, sort of augmented AI is probably the paradigm. Will that still be the paradigm in 2025, or will there be some physicians who will have been replaced by the iPhone?
I'm not for physician replacement. I don't think they can. This augmented intelligence is a much better model. What can get us from here to there, and I'm very excited about what can happen even in 5 years, is what Bob said in sort of a riff off of Gene Stead said, what this patient needs is a doctor, and what Bob says what AI needs is a doc. And that's absolutely true. If you think about why are we further along in self-driving cars, every model builder in that case is a driver. So they have the insights into what do you have to look out for in this cacophony of input you're getting, and we still don't get it all the way right, but at least they have a clue. In this healthcare space, you got to marry on an ongoing basis, on a weekly basis, the knowledge, the clinical insights that we're looking for with what the technology can provide and glean from the data. So that's extraordinarily important. If we did that, I think we could be doing a lot of things both in the delivery of care as well as caring for the people who are doing that delivery. So what do I mean? So physician and clinician burnout is one of the top areas. And there's a couple things. One, we talk a lot about all the extra work we have to do, the administrative work, but we also are being stripped a little bit away of the professional satisfaction of why we went into this field. How do we contribute back to the patients and their families the knowledge and experience that we've gotten? And that's a role for AI, for example. So let's say the preparation, the foraging for information that a doc has, whether you're in the hospital or the outpatient setting, of what's going on with this person, you'd really like to know. And most of that what's going on, yeah, you have all this structured data in their lab. What you really want to know is what's going on in the head of this person and then the head of the physician and the clinician. That is in the notes. And right now, the computer really doesn't have access to the notes. They really don't have access to the insights. So one of the areas where AI can play a role when you match the domain expertise with the technology expertise is to figure out what's contained, including social determinants, in those notes. So that's one thing, is how do we get to know quickly what's going on with this individual? The computer, as an augmenter, can help us do that. On the other side, and this was referred to earlier too, we have randomized controlled trials, but that's actually by its scientific method done on a very homogeneous population, which actually doesn't represent the people in this audience or in the world. And how do we complement, not substitute, but how do we complement that kind of evidence with this massive amount of evidence we're gathering and now documenting in the medical record? So now that we have these EHRs, we have these data, but we have to properly, that was also emphasized this morning, properly interpret that and bring that to life to help make the decisions that the clinicians are making more informed, both informed by the output of the RCTs, but also informed by this massive experience of all these people who have had multiple things done to them, but we just haven't tracked, well, what's happened next? And in particular, what's happened next to someone like this person, not some average, even an average in a trial or an average in a population. It's got to be this person. And fortunately, there's a lot of people like this person. What has happened to them? We sort of do that in our minds, like what other patients I've seen, but that's a set of 2,000 instead of 2 million. So those are the kinds of things that can, including what Meredith and Ronak are working with. How do we bring all that data so that we can say, what do I know about this person? Everything, including social factors, and what's the best possible decisions or recommendations I can make, considering all the experience that we currently throw away, but we'd like to glean out of these records.
Let me ask you about one other issue. We had an earlier question in the last panel about, well, do the skill sets of the clinician team need to change? And if so, how do we make sure they even know how to take advantage of these innovations that are coming down the pike? So what's your perspective on that?
We absolutely have to teach it in med school and training programs and go on with it. It's not just how do you use a computer. Yeah, we all think we use our iPhones, but it's how do you properly interpret data from observational data, including and RCT data, and then how do you properly use that, incorporate that into your decision making. Back in the 80s, we taught decision making, decision analysis. We've got to do that new version in today's world, and that really has to start with the AAMC. It's got to be the med school through training and through the ways that we attendings, communicate that. But it's dangerous not to include that. Just like we taught people how to use a stethoscope and later how to use an EKG machine, it's dangerous not to teach people how to use data and the output of analysis of data in today's world.
All right. Meredith, let me ask you one last question before we go to questions from you all from the audience. So in 2025, the Internet of Things will exist. There'll be sensors on anything you can imagine in the environment. There will be video cameras potentially that capture images. There will be our search behavior and the social exhaust that we create when we Twitter and do all kinds of other things. That all can have some very frightening aspects to it, and we will not talk about those because Jonathan and his crew will talk about that. What do you think is the potential in these technologies, and what would need to happen in order to take advantage of that for improving community health or population health efforts?
Yeah, I'm very excited. I feel like we are at a turning point in terms of being able to address social, behavioral, environmental drivers of health with much better resolved data. And so with combinations of AI, digital health, as well as EHR, et cetera, we're able to assess the drivers of health and then actually work towards prevention. And so one example that I think about every day in my job is better characterizing environmental exposure of our patients. And I think the explosion of lower cost air pollution sensors that are coming onto the market is really important to think about how do we better characterize environmental exposure of our patients through their daily activities, but also over the course of their life. And I think this has huge implications, not just for respiratory disease, but for any number of conditions, obesity, diabetes, cardiovascular disease, stroke, cancer. And so I think this will be really important. The new low-cost sensors that are coming onto the market, there's been a proliferation on the market. I think there's been a lot of really important work over the last couple of years to actually test those versus, instrument the gold standard regulatory instruments to really test validity and reliability so that we can use these data in dense networks across the city to really better understand exposure. I think there are interesting applications of machine learning in pollen assessment as well, which has important implications for allergy and inflammation and asthma. That has been a very manual process to date, but there are new image recognition programs that are really working to automate that process. And then I think we heard there are some NASA folks in the audience. I think there are incredible opportunities with remotely sensed data of profiles of air pollution through the atmosphere that I think is going to really be a game changer in terms of addressing air pollution exposure. But I think critical to making this useful is actually, it doesn't matter if we have all of these data if we're not actually translating it into something useful for an individual or for a clinician or for a community. And so we've really been focusing on, well, how do we use this data to help inform patients? And I wanted to bring up one example of a feature that we've developed at Propeller, which is really, it's a machine learning model, which is really trying to understand, it learns from an individual's past record of rescue medication use, where they've had the environmental conditions in which they've had symptoms, their clinical and demographic profile, and then can predict with fairly good accuracy, over 90% accuracy, whether someone will use their rescue medication on that day, given their environmental conditions on that day. And just from a user, we've done a lot of user research on this feature, and to try to understand how people actually use that information in their day-to-day lives. And it has been not only, it's not perfect, of course, but in terms of how people use it, it's been the most used feature at Propeller, but also the most loved feature at Propeller. And people are using it, in the morning, waking up, using that information to better understand what their daily challenges might be, but making decisions about how they might behave that day, whether they'll go outside to exercise or not, whether they'll be sure to take their controller medication on that day, or whether they'll carry their rescue inhaler use. So I think really critical is understanding that bigger picture of social determinants of health, but actually translating that into what can someone do about it on a daily basis.
Let me follow up with one quick question. So would you imagine 5 years from now that there's sort of a minimal or minimum set of data that is connected, i.e. sensors with, I don't know, personally generated information from your Apple Watch with something else? Because to some extent, we have sensors now. Is there some sort of exponential opportunity that we could be taken advantage of by this connectivity?
Yeah, I think it'll be really interesting, again, to kind of connect the individual in the community. So these ubiquitous networks of sensors, air pollution, traffic, movement sensors that can help us understand context, but then how is an individual actually moving through space? What is their behavior like? How can that be modified to improve health? So using Apple Watch, for example, to understand steps throughout the day. How is that related to their respiratory symptoms? So I think there's a lot of really interesting applications for, again, both the individual and the community level of understanding.
Great. All right, so now we are moving to the audience participation part. So I believe there are 2 mics that are moving through the audience. So please ask your questions. And if you could first introduce yourself and your affiliation before asking the question, and maybe direct it to one or more of the panelists.
Sure. My name is Gary Bacon, and I am, fortunately for me, it would seem, a retired radiologist. The question is, where does the United States stand in relation to other countries in the use and function of AI? And I'm thinking of Germany, Japan, Scandinavia, China, the Eastern Bloc countries. Where are we? And if they are using it more or getting more results, are their outcomes any different than ours?
That's a great question. A big condition for using AI is to have the data. And as you know, we have struggles in this country, even though we've sort of put data in computers, getting them to cross has been a challenge. That's also a challenge in many parts of the world. You know that China has huge investment in AI, for example, but they also have very little health-related data that's computerized, so that's going to be a challenge for them. One of the areas, the Scandinavian countries have one of the best collections, actually some including genomics, data on their population, and they protect it very well from a privacy point of view, but they would have a rich data set, and with the right technology and the right methods could leverage that. And I hope over time there's international collaboration so that we can start sharing what we know about people and their behaviors. I want to piggyback on what Meredith said. I think it's a big frontier. I think Lloyd mentioned how 70% is really the what we do to people. It's really their behavior and the social determinants, et cetera. It's more important to know what causes somebody, how do they react to the data, whether it's on the environment or their own data and whether they should take their inhaler today. That would give us much better insight on how to improve the health of an individual and a community. So very great question. I don't know that anybody else is further along in applying AI in health, partly because of the limitation in data. And we sort of catapulted as a result of high tech in our collection of data on ourselves.
And I want to just add that Japan specifically has invested a lot, and again, it's not necessarily scaled at the society level, but a lot of the innovations around aging supports are actually coming out of Japan because Japan is already in the middle of a major aging crisis because of their social structures and because of how the population has been. But again, recognizing that some of the aging crisis is coming from their social structures and the social systems that exist around gender roles and such. So people are not wanting to have families because they don't want to get sucked into caregiving roles that they're not ready for. But so there's innovations that are coming out. A lot of the robotics that are coming out to support aging and isolation and aging and loneliness and dementia are coming out of Japan.
Great. And another question. We have lots of questions here. Okay, in the back, please.
Hi, my name is Renee Ameling, and I'm a sociologist at Yale, and this year visiting Stanford at the Center for Advanced Study in Behavioral Sciences. And my question was really inspired by this really fascinating study of Louisville and thinking about the social and environmental determinants of health, and really wanting to raise a question about what we think of as artificial when we're describing artificial intelligence. Because I think that that generally refers to these machine learning techniques, but we can also think about it as describing the data, right? We keep talking about the data, the data, the data. And that data is human produced, and we don't record everything, and we choose what to record and what not to record. And so I wanted to think about what data is not collected and what can't be put into these algorithms if we're mostly focusing on individual level indicators of health, and how, not just in asthma, but maybe for other conditions as well, what it would mean to really take seriously these social and environmental contributors to disease. Thanks.
Great, yeah, and very interesting questions. In terms of what is not collected, I mean, I think there's been, and kind of getting to the European question as well, I think there's been a little bit more of not a resistance, but we perhaps are not quite as far in the process of integrating fully the social and behavioral and environmental drivers of health into healthcare decision making. I think that certainly there's a lot of movement in that way, and I think it's definitely being addressed at a patient level in terms of identifying social vulnerability of a patient and referring out to relevant services. But I think really kind of taking it to the next level to better understand, well, a patient lives here in this community, let's explore all of the different community level factors that may be influencing them in their day-to-day. You know, how walkable is their street, and do they live within 300 meters of an industrial site? Those are big questions that we started to really address in Louisville, because there is quite a lot of industrial emission exposure, and especially for more disadvantaged populations. So I think it's really critical to start adding that into addressing treatment as well.
I love the question as well, because I think the best way to increase the data that you capture and can use is to do something actionable for the person that's donating the data. So that helps with the completeness and the quality. On the way here, the GPS system, you like the traffic, and that's how it predicts when you're going to get there. And then it popped up with the screen saying, hey, would you like to share your data so you can have more of that? And so this time I hit yes, even though I had denied it before. But I saw how that's the only way it's getting traffic information is for me to share my data. It's the same thing, I think. The things that will benefit back to yourself or your community are opportunities that you'd like to act on.
If I could just add to that point, actually, with one more example from Louisville, we surveyed participants who joined the program to see why they joined. This was our first attempt at doing this. We wanted to understand why they were being a part of the program, and overwhelmingly, the two reasons for joining was, one, to improve my own outcomes, but secondly, to contribute to something bigger, and to really contribute their own personal data to better understanding, patterns of disease across the community. And that was very strong signal, and I think really shows the promise of, people are open to this and excited about contributing to something bigger.
We'll have time for one more question. Okay, there you go.
My name is Daphne Scott Henderson. I'm a clinical informatics educator at Stanford Healthcare. I'd like to know, what do you guys think is the next step in the integration of AI and the EHR?
It's got to be in the workflow. Nothing we do, whether any person does, is a detour. And of course, all of the consumer applications know this same thing. In the healthcare space right now, everything certainly the doctors do and the clinicians are all in the EHR. And if it is not taking advantage of the information that you put into that EHR and then give you actionable advice or input, then it's not going to happen. So we have to move. I think there's partnership, and already, even we've worked with EHR vendors to make sure that that bi-directional thing happens. Get the data, do something useful for the end user, and then put back that use back into the data.
Let me ask you about one other aspect of that. One of the issues that we discussed as we were writing this report is this issue about transparency and explainability. So do you think it is foreseeable that physicians or clinicians would not trust a recommendation because they don't understand how that came about? Or what would we need to do that they do trust it?
Of course they're not going to do something that they don't trust. That would be the default case. So it goes back into the training on how to use data. First, we have to teach them how does, quote, AI analyze data. What are the limitations? You're going to hear a lot more about that in the panels today. But they have to know that going front. And then they need to see the transparent access of, well, how is this machine or this algorithm using the data? Why is it? What are the important influences in that model it's processing the data with? And just make that transparent to me. Over time, just like we have hyperlinks to the literature, you read it a couple times and you say, they do a pretty good summarizing, and I don't read it anymore. But I need that initial, before I believe it, and then I'll decide what I'm going to believe going forward.
All right. Well, the hook has arrived in the form of Sonu. So thank you very much, Meredith, Paul, and Ronak, for a great panel.